Hello and welcome to our symposium, Multimorbidity Across Swedish and U.S. Aging Cohorts, Understanding How It Develops, Whom It Most Affects, and When It Cascades. My name is Dr. Heather Allure. I am a professor at the Yale School of Medicine in the Department of Geriatrics and a professor of biostatistics at the Yale School of Public Health. Today, our first speaker is going to be Professor Amaya Calderon Larrañaga with co-author Federico Triole, and they will be presenting determinants of multimorbidity, insights from the population-based Swedish National Study on Aging and Care in Kungsholmen, SNAC.
So hello, everyone. My name is Amaya Calderon Larrañaga, and I am Associate Professor at the Aging Research Center at Karolinska Institutet in Sweden. And the title of my presentation is The Determinants of Multimorbidity, Insights from the Population-Based Swedish National Study on Aging and Care in Kungsholmen, SNAC as we call it. And I take advantage to say that I have no potential conflicts of interest to report. Right, so before I start, and as a brief introduction, I would like to very quickly remind ourselves of what we already know about multimorbidity when it comes to old age. And we definitely know that it's the most common chronic condition, whether it's in primary care, in the community, in nursing homes. We also know that it is associated to multiple factors, and that these factors are indeed multidimensional. So they can be socio-demographic, they can belong to the biological domain, or they can also belong even to the psychosocial domain. We know that multimorbidity is related to negative health outcomes, not only related to, for example, the drugs that people with multimorbidity take. In this sense, we know that subjects with multimorbidity are more likely to suffer from safety problems. They're also more likely to suffer from ineffectiveness problems related to drugs, but also to the so-called higher treatment burden, which is also negative per se. But subjects or patients with multimorbidity also tend to receive worse care in terms of the coordination of this care and the continuity of this care. And last but not least, we do have some accumulating evidence that patient-centered medicine should be or should guide the practice or the care that these older people with multimorbidity receive. We have more and more studies, more and more models pointing towards the need for this patient-centered care. Most of these models published in these recent years point towards how we should identify the needs of these people with multimorbidity. What they are less clear about is how these models or how these indications should actually be put in practice. But anyhow, overarching these four well-known statements, there is still one aspect that remains largely unknown and unanswered, which is how should the burden of multimorbidity be operationalized to make it a meaningful concept, not only from a research perspective, but also from a clinical perspective. Multimorbidity has been traditionally defined as the coexistence of two or more chronic conditions in one same person, but we know that the cutoff of 2+ is actually very poor when it comes to discriminating or differentiating the enormous heterogeneity in older adults' health status. If you see here in the figure, you see that we have on the x-axis, we have people over the age of 60, and then across the y-axis, we have different numbers of coexisting chronic conditions. Well, out of this community-based population, age 60 and plus, we see that almost everyone was actually suffering from 2 or more chronic diseases. So this is to say that if we want to do a good job in capturing this complexity of the morbidity burden in older adults, it is a lot more likely that we do better if we understand multimorbidity as a continuous grading scale instead of a yes-no dichotomy or a categorized variable. And precisely along those lines, our research team has importantly worked on developing a new way of operationalizing multimorbidity in the recent years. And this is precisely the use or the analysis of the speed of chronic disease accumulation. So we believe that the speed of chronic disease accumulation or multimorbidity accumulation is actually a proxy of the speed of biological aging. So if we see the graph here below, indeed the rate of aging or the speed of aging is actually a very dynamic equilibrium between external stressors or threats that the body receives. And these are the pink arrows, and then the compensatory or resilience mechanisms, the green arrows. So, depending how strong these pink and green arrows are, this is actually going to shape the speed at which we age, or in other words, the speed at which we accumulate chronic conditions. Indeed, it has been shown that not only baseline levels of IL-6 being a biomarker of inflammation, but also the changes over time of IL-6 is a very good or is very closely correlated with the speed of chronic disease accumulation. And remember that inflammation or the levels of IL-6 are a good marker or proxy of one of the hallmarks of aging, which is the process of inflammaging. So we believe that under our understanding that the speed of multimorbidity accumulation is actually a proxy of biological aging, given that if we're actually able to identify those threats and stressors, but as well as those compensatory mechanisms that shape this speed or rate, well, then we could eventually think of preventative strategies to avoid or at least delay the fast accumulation of chronic diseases. So based on that, we have done quite a lot of work looking at the potential determinants of the speed of chronic disease accumulation using data from the Swedish National Study on Aging and Care in Kungsholmen. This is a community-based or a population-based study of people aged 60 and over, and it started in year 2001, and it is actually still ongoing. What is interesting about the SNAC case study, which is carried out in one of the districts of central Stockholm in Sweden, is that in each of the waves, participants undergo a very comprehensive interview by physicians, nurses, and psychologists. And this leads to a very comprehensive picture of the social, physical, and functional health of these individuals. Now, based on these data, I'm going to show you the results of different studies where we have tried to identify potential determinants of multimorbidity development and speed of accumulation. And I'm going to start with this first study published in 2019, where we looked at the association of lifelong risk factors with the speed of chronic disease accumulation. And I'm referring more specifically to factors such as father's occupation during childhood, early adulthood education, job strain in midlife, and or social network in late life. And what we see in each of these cases is that high early adulthood education, an active job in midlife defined by a job that is that has high control but also high demands, as well as a large or rich social network in late life, are all associated to a slower accumulation of chronic conditions. And it was quite interesting because in further analysis where we combined each of these different exposures, we saw that social network seems to be a especially relevant potential protective factor of the speed of disease accumulation, even able to counteract the negative effect of the stressful job exposure in midlife. The next exposure or potential determinant that I want to speak about is related to psychological well-being. We have looked at the association of both life satisfaction measured through the life satisfaction index, as well as the negative or health outlook levels. And we looked at their association with two outcomes: the speed of disease accumulation, but also the speed of disability accumulation, both in basic and instrumental activities of daily living. So what we see in both cases is that low life satisfaction and a negative health outlook are related to faster accumulation of both diseases, but also disabilities. And we speculate that this is probably because of how correlated these psychological well-being measures are with aspects such as self-management or the use of external aids to prevent dysfunction and dependency. This other study looks at the association between depression severity and multimorbidity accumulation. And what we did here was to first classify our SNAC population into 4 mutually exclusive categories or diagnosis of depression across the depression continuum. We had 90% of the people who did not have depression, 4% who had subsyndromal depression, 5% with minor depression, and 1% with major depression. And what we see indeed is that both subjects with major depression, as well as older people with subsyndromal depression, actually show a faster accumulation of chronic diseases. And this points out towards a potential interest of depression, well, not only its identification, but also its treatment in order to prevent this rapid accumulation of diseases. We also looked at the association with sleep disturbances, which is measured in SNAC-K by physicians using the comprehensive psychiatric rating scale. And what we see here, once again, is that people with a moderate to severe sleep disturbances actually show a faster accumulation of both neuropsychiatric chronic conditions as well as musculoskeletal chronic conditions. We did not find such an association for cardiovascular chronic conditions, probably because of the selection of these individuals. People with several cardiovascular diseases tend to die earlier. We also looked at the association of BMI trajectories, body mass index trajectories, with the accumulation of diseases. We find 3 BMI trajectories in SNAC-K. One that is a stable trajectory, which groups 80% of the people. One that is called slow BMI decline trajectory, which groups 18% of the people. And one with a rapid decline, which groups 2% of the people. And what we see is that this fast BMI decline trajectory is actually linked to a more rapid disease accumulation in general, but also specifically in terms of cardiovascular diseases and neuropsychiatric diseases. So this indicates the potential, this indicates that actually a sustained and rapid decline in BMI could be an interesting indicator of a future fast accumulation of chronic conditions. Now, the last 2 slides refer to 2 groups of biomarkers that we have analyzed in terms of their association with a rapid chronic disease accumulation. One is glutathione. It's a non-essential amino acid, and it's linked to multiple cell-related factors. It's linked to, it has a very powerful antioxidant effect, but it's also linked to the cell cycle and cell death. And that is why glutathione levels have been linked to many different individual chronic diseases. What has not been shown yet, but was shown in this study from 2019, is that serum levels of total glutathione, so when I say total, glutathione is both the oxidized and reduced form, is actually also associated with a faster accumulation of chronic diseases. So higher levels of total glutathione are associated to a faster accumulation of chronic diseases. And linked to glutathione, another 2 biomarkers that we analyzed were homocysteine and methionine. These are both part of the homocysteine cycle, and they have many pleiotropic functions that are linked to many different functions, such as DNA synthesis and repair, lipid metabolism, telomere length, oxidative stress, inflammation, and also very interestingly to DNA methylation. In fact, the methionine to homocysteine ratio has been indicated to be a good proxy of this methylation status, whereby lower levels of this ratio, methionine homocysteine ratio, would be associated or would be expected to have more harmful effects. And indeed, this is what we see here. We see that on the left-hand side, higher levels of blood homocysteine, lower levels of methionine, as well as a lower ratio of this methionine homocysteine, are all associated with a faster accumulation of chronic conditions. So this latter finding, the one linked to the methionine homocysteine ratio, together with another finding that I didn't present here, which was linked to the role of the NTHFR 677CT polymorphism. So we saw an interactive effect between this polymorphism and the methionine to homocysteine ratio. So these two indicate that probably this DNA methylation degree or methylation levels, low levels of methylation could actually be indicating or somehow linked to the cardiovascular pathology. I'm not sure if I said this already, but in this study, we only focused on the speed of cardiovascular disease accumulation. So in conclusion, in older people, considering multimorbidity as a yes-no phenomenon has very little discriminative power. Instead, older adults tend to have, or the multimorbidity is presented in older adults in a very complex and very dynamic way. And therefore, we believe that exploring the speed of disease accumulation could provide promising opportunities to study not only the dynamics of aging, but also probably all of these multi-dimensional, multifaceted, and life course determinants of disease development or disease accumulation. So thanks a lot for your attention. I would also like to take advantage to acknowledge SNAC participants and the staff, co-authors and collaborators, as well as the different financial sources of economical support. Thank you.
Thank you very much for that presentation. We'll be holding questions for discussion at the end. Our next presentation is going to be the accumulation of multimorbidity, patterns and variation by race, ethnicity, and body mass index from the U.S. population-based health and retirement study. This presentation will be by Drs. Ana Quinones, Associate Professor at the Oregon Health and Science University, and Anda Botanescu, Associate Professor at the University of Michigan.
Thank you so much, and thank you for joining us today for our talk. We'll be discussing multimorbidity across the United States in some aging cohorts. We will be focusing on how it develops, whom it most affects, and when it cascades. Both myself and Dr. Botosaneanu will be co-presenting this talk. We'd first like to note that we have no disclosures to report, no financial conflicts of interests, but we do note that we receive funding from the National Institutes of Health, National Institute on Aging, and the views expressed in this talk are our own and don't necessarily represent the official views of the NIH. Wanted to start with some background and noting that multimorbidity in the United States and really globally across the world is incredibly prevalent, and particularly with older age. So in the US, adults aged 50 and older, middle-aged and older adults, approximately 2/3 have multimorbidity, have 2 or more coexisting diseases, and this increases over the age span. So when we break it down and look at adults aged 50 to 65, about half have multimorbidity. When we look at ages 65 to 74, about, again, almost 2/3 of that population has multimorbidity. And once we look at older adults who are the oldest of the old, older than 75 years of age, the vast proportion, the vast majority have multiple chronic conditions, about 82%. So we'll be discussing data, population-based representative national data from the Health and Retirement Study, which is collected out of the University of Michigan's Institute for Social Research. This is a biennial, nationally representative community sample. So these are adults living in the community, not institutionalized, and it includes adults aged 51 and older. Once you're age eligible and you consent to participate in the HRS, you become a recurring respondent in the HRS, and there are truly repeated observations upon study entry. And to date, approximately 43,000 people are surveyed in the HRS. Now, these data permit us to look at a variety of questions. These overlapping birth cohorts designs really show that capacity to ask questions across age, across period, across birth cohorts. And we see that the HRS started their data collection in 1992 with the original HRS birth cohort. In 1995, 93, and 95, the oldest of the old were sampled. And then starting in 1998, there was a consolidation of data collection across the original 2 HRS and ahead birth cohorts, as well as 2 additional refresh birth cohorts with the children of depression age and the war babies. And from then on, in 2004, the earliest baby boomers started to become age eligible and integrated into the HRS, mid boomers, late boomers, and then starting in 2022, this year, the earliest of the Gen X birth cohort started to become age eligible into the HRS. So I wanted to turn now and talk about a few of our studies that examine how multimorbidity develops in the US context using these national population-based data from the HRS. We also want to talk about whom it most affects and how it cascades. But in this first study, we sought to trace the trajectory of multimorbidity accumulation, which we operationalized as the count of chronic diseases over mid and late life, across white, Black, and Hispanic middle-aged adults over a 16-year period. So we aligned study participants by age, and we assessed the onset of multimorbidity across these 3 different racial ethnic groups using growth curve trajectory analyses. And we found that multimorbidity is common in late life, which corroborates many other studies' findings across national settings. We also found differences in the average age of multimorbidity onset by racial ethnic group. So we see multimorbidity occurring earlier in midlife, around late 50s, early 60s for Black Americans, but closer to retirement age, around mid 60s for white and Hispanic Americans. So to dig a little bit further into these differences by race ethnic group, we found specifically that Black Americans started off with a higher initial level of chronic disease burden compared with their white and Hispanic peers. And they crossed that multimorbidity threshold on average about 4 years earlier than white Americans. So you'll note also that our findings show that while Hispanic middle-aged adults had comparable initial levels of disease compared with non-Hispanic white Americans, they were accumulating chronic disease at a faster rate over time. So we also wanted to talk about whom it affects, whom multimorbidity disproportionately affects using these US population-based data. And this is a paper published in the Journals of Gerontology in 2021, excuse me. We're trying to look at those dates on very small screen. And here we also noted some very, very interesting differences by risk factors, by BMI category. So we saw very similar initial counts of disease, again, at that earliest middle age time frame, age span of 51 to 55, across all BMI categories. We did see we did see a faster accumulation of disease among participants with obese BMI, and in particular that obese, that most obese category, that obese 2-3 category, compared with those with normal BMI. And then we also see that overweight BMI, so similar to normal BMI in both the initial count and in the rate of accumulation of diseases. What's interesting here is that we see some very marked differences by racial ethnic group and BMI category. So that middle plot displays the trajectories of chronic disease accumulation for Black Americans, and we really see that shifting earlier in the age span. So Black adults in all of the BMI categories pass that multimorbidity threshold substantially earlier than non-Hispanic white and Hispanic participants. We also note that Black Americans with normal BMI reach that multimorbidity threshold about, again, 4 to 6 years earlier compared with whites with obese 2-3 BMI, so obese 2 and obese 3 BMI categories. And then Hispanics, again, start with lower counts of disease, but otherwise are quite similar to non-Hispanic white adults across the BMI categories. So turning now and thinking about how multimorbidity cascades, how it evolves over time, how it changes and progresses, there's one more study that we wanted to share, and this one is published here in Medical Care. You can search for it and read it on your own time. But we wanted to discuss, again, the general findings here with relation to this talk and thinking about how multimorbidity evolves and cascades over the age span. So we estimated trajectories in multimorbidity combinations here. So these individual chronic diseases, how they clustered together in latent classes using latent class analysis. And we compared across non-Hispanic white, non-Hispanic Black, and Hispanic middle-aged adults over a 16-year period. So from 1998 to 2014. Also wanted to note that in these analyses, we assessed these empirically determined multimorbidity combinations using those latent class analyses, and we included combinations of both physical or somatic disease as well as mental health conditions. So here we found that overall there was substantial progression to more severe classes of multimorbidity, to death, and to loss to follow-up. So two important findings that I'll highlight. So it's perhaps not surprising that study participants in this cardiovascular, musculoskeletal, mental group at the beginning of the period were more likely to move to the most complex multi-system multimorbidity group. They were also more likely to be deceased or lost to follow-up by the end of that study period, relative to participants in that minimal disease group at the beginning of the period. We also reported important findings with regard to non-Hispanic Black and Hispanic study participants. So both of these racial ethnic groups were more likely to be members of that most complex multi-system class at the end of the period. And they had higher probabilities of belonging to, progressing to death or to loss to follow-up compared with non-Hispanic white participants after we controlled for and accounted for initial group membership. So wanted to close here and thinking about where do we need to go? Where do we need to go toward that next generation of multi-level, of effective multimorbidity disparities research? So ultimately, we need to continue to shift our focus away from organizing healthcare solely around addressing episodic or acute problems and toward more high quality and proactive chronic care management that takes into consideration coexisting disease, as well as personal circumstances and social structural conditions. So in doing so, we need to really prioritize prevention earlier in the life course for vulnerable groups, particularly for Black Americans, and as we saw in our studies, particularly for Black Americans with obesity. We also need to further our understanding of how multimorbidity develops, how it progresses, and then how it results in health cascades, those health-related impacts of multimorbidity. We particularly need to be more cognizant, more aware, more proactive around how these dynamics affect vulnerable population groups. These are disproportionately affected groups. They're disproportionately affected by these complex disease patterns and poor progression of disease. So we must also be aware that for certain population groups, risk factor conditions such as obesity, it is associated with poor progression, but the impacts of multimorbidity really extended beyond and across the full spectrum of BMI for Black Americans. So overweight Black Americans, obese 1 category, as well as obese 2 and 3. We noted higher impacts of multimorbidity for those disproportionately affected Americans. And then finally, in an effort to evolve healthcare delivery models and to be more responsive to population level chronic disease care needs, we really must be thinking about innovating the delivery of care to provide and connect to services that maintain good levels of quality of life, that are proactive enough to identify, to avert, to delay these preventable health cascades. And this includes both the mobilization and navigation between clinical and community resources. So I wanted to stop here and acknowledge our co-authors, our collaborators, our analysts, as well as many, many colleagues and reviewers whose feedback has really helped to improve our work and has helped to review the work that we've published to date. Thank you so much. Dr. Botosaneanu and I are available for your questions. Thank you.
Thank you very much for that presentation. This was really complements our previous speaker from the Swedish perspective, and we will have discussions at the close of our final presentation. Our final presentation is entitled Social Support and Social Strain as Predictors of Depressive Symptoms and Accumulation of Chronic Disease Following a Marital Transition. This is presented by Emily Denning, who is a graduate research assistant at Portland State University.
Hello, my name is Emily Denning, and today I'm going to be presenting on the effects of social support and social strain as they affect recoveries from marital transitions. Marital transitions, including widowhood or divorce, are stressful experiences for older adults, and they've been shown to be detrimental to health and well-being. Previous work shows that marital transitions are often followed by a drop in mental health, followed by a gradual recovery. Divorce rates among older adults have been increasing in recent years, and work has begun to examine these experiences together. Previous work using the same data set as the present study found that compared to widows, people who experienced divorce had a smaller increase in depressive symptoms and a faster recovery following their marital transition. Social relationships or social exchanges have also been shown to have powerful impacts on older adults' mental and physical health. On the more positive side, social support or positive social exchanges have been previously shown to be beneficial for the mental health of those who have recently experienced a marital transition. On the more negative side, social strain or negative social exchanges have been demonstrated to have negative impacts on the self-rated health of older adults. Most of the work that's looked at the effects of social relationships on recovery from marital transitions has often been focused either solely on widows or solely on people who have experienced divorce and not compared them together, or has been largely cross-sectional. Therefore, we utilized health and retirement study data from 2006 to 2016 to examine the impact of social support and social strain on mental health and chronic disease trajectories following a marital transition. The HRS is a biennial survey of US older adults, and participants were included in the present analytic sample if they had experienced a single marital transition between 2006 and 2016 and were at least 50 years old. This resulted in an analytic sample of 377 participants. The sample was about 53% divorced and 47% widowed, about 58% female, 42% male, and the rest of the characteristics largely reflected the larger HRS sample. Depressive symptoms were measured using 7 items from the CESD, where participants reported how frequently they experienced 7 different depressive symptoms. These responses were then dichotomized according to whether they had or had not experienced those symptoms to create a count of depressive symptoms for each wave. Multimorbidity was measured using the count of 8 chronic conditions, including hypertension, diabetes, cancer, lung disease, heart disease, stroke, arthritis, and cognitive impairment. Social support and social strain were measured prior to marital transition, either 1 or 2 waves, which is either 2 or 4 years, as these were asked in the Leave Behind questionnaire, which is asked to a rotating subsample of participants every other wave. These measures, both social support and social strain, were asked in reference to 4 sources: spouse, children, family, and friends. In order to investigate these trajectories of depressive symptoms and chronic conditions, we utilized piecewise growth curve models with individually varying time codes in M+. This modeling approach allows us to line participants up according to when they experience their marital transition, and allows us to estimate the slopes leading up to and following their marital transition separately. First, we estimated these models unconditionally, then with covariates and social support and strain predictors of these trajectories. We tested separate models for depressive symptoms and multimorbidity, and due to the fact that it can be significant predictors of these slope factors can be interpreted as an interaction, simple slopes were computed to examine significant predictors of these trajectories to probe the associations further. Covariates included type of marital transition, so either widowed or divorced, sex, age at marital transition, years of education, race, ethnicity, and net worth at marital transition. Starting with the depressive symptoms results, the unconditional results of the piecewise models, I should also add, all these results are unstandardized due to modeling limitations. The average intercept was 1.65, indicating that on average, participants reported 1.6 depressive symptoms at wave of marital transition. The premarital transition slope was not significant, indicating that on average, participants were experiencing stable depressive symptoms prior to their transition. And we see that the post-marital transition slope is significant and negative, which tells us that on average, participants are experiencing a reduction in depressive symptoms or are recovering from their transition. Moving on to the models with covariates and social support predictors. First, we can examine the widowhood versus divorced indicator, which tells us whether there are mean differences on these based on compared to those who are widowed and divorced. And we see that at wave of marital transition, or intercept, there's no significant differences between those who are widowed and divorced, indicating similar levels of depressive symptoms at that wave. However, we see that both slopes before and after marital transition do differ significantly based on the type of transition. Specifically, those who were divorced were more likely to decline in their depressive symptoms prior to their transition than widow individuals, and were more likely to increase in their depressive symptoms following the marital transition than widowed individuals. Both social support from spouse and social support from friends emerged as significant predictors of these post-marital transition depressive symptom slopes. However, social strain factors and social support from other factors did not emerge as significant predictors. We examined the effects of social support from spouse at varying levels to better understand the ways that these slopes vary according to these social relationships. At high levels of social support from spouse, so those who had the closest and highest quality relationships with their partner prior to their transition, experienced stable depressive symptoms or slopes that didn't differ significantly from zero, indicating that they had more difficult times recovering. Whereas at mean and low levels, we see negative slopes, indicating a reduction in depressive symptoms. A similar but opposite pattern emerged from social support from friends, where we see that people who reported having low social support from friends prior to transition experienced a more stable slope, indicating more difficult recovery, where at mean and high levels, people were recovering faster. Now turning to the results of the models examining multimorbidity trajectories, we can begin with the unconditional results, which indicate that on average, participants were experiencing 2.28 chronic conditions at wave of marital transition. Both premarital transition and postmarital transition slope were significant and positive. Turning to the models with covariates and social support predictors, we can again examine whether there are differences between those who are widowed and divorced. Interestingly, in this model, we do not see any differences between these groups, indicating that the effects of a marital transition on one's chronic conditions does not appear to differ between those who are widowed and divorced. Social support from children was the only significant social support predictor of these recovery trajectories. We further examined this effect by computing simple slopes. And interestingly, we can see that at low levels of social support from children, the slope is essentially zero, indicating that participants are not accumulating chronic conditions. Whereas at mean and high levels, we see positive slopes, indicating that at higher levels of support, we're seeing higher rates of accumulation of chronic disease. It's entirely possible that this result is showing us that as people experience greater chronic condition burden, they are then turning to their children for greater support. However, more work should be done to disentangle this association. Specific sources of support appear to have distinct associations with mental and physical health recoveries following a marital transition. These findings may help us identify who is at greater risk or who may need more support from formal sources. These findings indicated that more spousal support or a closer spousal relationship prior to transition is associated with a more difficult or a slower mental health recovery. Social support from friends, on the other hand, was associated with a faster or less difficult mental health recovery following a marital transition. This suggests that clinicians may be able to identify people who had very close spousal relationships but lack friend support, as these folks may be especially needing of more formal sources of mental health support. Interestingly, social support from children was positively associated with chronic condition trajectories. This suggests that children may be helping support their parents and carrying some of that burden of having multiple chronic conditions. More work needs to be done to better understand why this might be happening and how we can better support people who've experienced marital transitions and their children who may be supporting them. We also found that people who were widowed and divorced had similar levels of depressive symptoms at marital transition, however, differed in their trajectories. We did not see these differences, though, in our models looking at multimorbidity trajectories. By examining these together, it allows us to illustrate some of these similarities and distinctions in the experiences following a marital transition, as it appears that these experiences may have differing impacts on one's mental and physical well-being. In conclusion, marital transitions are stressful events that impact the mental and physical health of older adults. In these analyses, social support from spouse and friends both emerged as important for mental health recoveries, whereas social support from children appears to be related to multimorbidity trajectories. The ways in which social relationships affect mental and physical health after marital transitions appear to be complex, and they're important to examine in order to best support older adults as they move through a stressful experience. Thank you, and please feel free to email me with any questions. And here are my references. Thank you.
Thank you very much, Emily. This was a very helpful and insightful presentation, and this leads us now to the question and answer period and discussion. We look forward to engaging the audience in their questions.
Thank you so much for the presentation. So I just wanted to confirm that we didn't have any questions from the audience, and I'm not seeing any in the chat box. So I'm going to assume that we don't have any. So Amaya, maybe we can take this opportunity to, now that we've had a chance to see each other's presentations and have a chance to discuss maybe some parallels or some questions that we might have regarding our very similar research interests in examining multimorbidity progression and multimorbidity accumulation in our two very different national contexts of Sweden and the United States, and maybe what struck out for you to be some commonalities or some differences.
Mm-hmm. Sounds like a plan. If you want, I can start. I made like the brief summary.
Commonalities or some differences.
Mm-hmm. Sounds like a plan. If you want, I can start. I made like the brief summary of commonalities that could be strengths for this kind of research that we do, which has many points in common, especially after listening to both of your presentations. So I think we are both speaking about longitudinal cohorts with a sufficient time of follow-up to capture all this dynamism that we see, not only for chronic diseases and multimorbidity, but any health parameter that we can think of. I mean, we've also done some work on physical function, for example, and we see that it's something that increases, but it increases. I mean, the decline in physical function becomes steeper also with as we move towards older ages. So it's only if we have this kind of long follow-ups across the whole age range that we can capture this dynamism of these parameters, and that I think is a commonality among these strengths, I would say, among these two cohort studies. The second is that I think we have a good assessment of chronic diseases. Emily was saying in her study she was assessing 8 diseases, but I think you have covered more diseases, Anna, right, in your second study?
Yeah, it's variable.
Yeah, exactly. So I think that's also important. If we want to understand multimorbidity, we definitely need to focus on those diseases that are most prevalent and therefore most relevant in epidemiological terms, but also most relevant from older person's perspective. So, we have some diseases that are less prevalent, but are still, have a huge impact in older people's lives and therefore deserve enough attention. So I think that's also something interesting. When it comes to the assessment of chronic diseases in SNACK, we put together many sources of data, the self-report, the electronic health records, the physician interview. And I think that's how we achieve a quite precise assessment of these diseases. And I would say the third point is that we have a huge range of potential determinants that are associated with health, diseases, disability, survival, whatever outcome we decide to look at. And that is a huge strength. That is what I think is most enlightening, what makes us aware that the social determinants of health or psychosocial determinants of health that you have spoken about, that Emily has spoken about, that I myself have spoken about, are very important also in how multimorbidity, the rate of disease accumulation is shaped. So I think those are three commonalities that are, strong points of both cohorts. One thing that now I realize how important it is actually to start looking at aging before people have actually, attained the old age, or what we understand is old age. SNAC-K starts at the age of 60. And I think after your work and Emily's work, we realize how important it is to pull back this threshold to lower age ranges and start looking from, I think, late adulthood or, midlife or late life. And what else had I written here? So I think that's one of the things that SNAC-K lacks, as I say. And then perhaps one thing that we are more and more working towards is actually taking diseases into account, but also together with other health parameters that are also important in old age. So, diseases, but function is important, cognition is important. And I think while we analyze and we look at multimorbidity and the speed of multimorbidity accumulation, we do not need to forget about these other dimensions that need to be, I think, looked at simultaneously to get a good understanding of what is happening there. And that's my summary.
Absolutely, that's great.
Yeah.
So that gave me a lot to chew on and a lot to pull on. So Emily, if you want to start thinking about and formulating any kind of high level observations that you might have, I can jump in and talk about mine. And I wanted to approach it. So I want to dovetail off of what you just summarized, Amaya. Thank you for that. But I also wanted to pull on maybe a couple of questions that emerged for me in listening to the diverse presentations, in listening to the results across the SNAC-K Swedish cohort and the US cohorts that Emily and I both work with. There's some really interesting questions that I thought about in terms of trying to compare and contrast. A lot of findings that, as you point out, really align quite nicely, but then some interesting little components. I'm trying to put that together in some kind of a conceptual framework. So a lot of what I agree, a lot of what I saw there, a lot of the work that you and your group has done around these clinical, the biomarkers, the combinations, the progressions, really interesting and really starting to pull that out, which we're now just starting to look at some of the limited biomarkers that are collected in the health and retirement study, but very much of importance, and really trying to, I know that we cannot really dig into the severity of multimorbidity. It's very difficult to get to the severity of multimorbidity, given that everybody operationalizes it somewhat differently, different combinations of conditions, and each condition itself might be at different severity levels. So that's a real challenge for the field, I would say. I think a lot of the work that your group is doing in trying to think about different markers that may give us more information about severity of those existing underlying multimorbidity combinations, such as your sleep, such as other things that we might think of as maybe symptoms or indicators of poor progression or indicators of homeostatic dysregulation, as your group has done. I thought that was very, very interesting. But then the social factors component, to me, there was a lot of alignment there across the two different cohorts, which I find extremely fascinating. I think there's a lot of opportunities there and questions around different social structures, the importance of different social factors. And I think a lot of what Emily's work speaks toward in terms of social cohesion or social support, social networks, the different importance of those kinds of factors in mediating or potentially mediating, but moderating these relationships across different national settings, I think is very interesting. And then one question that I had regarding the work that I saw all three of us present was around, so we were all very interested in these longitudinal, time-based accumulations, progressions, changes. I'm very curious about the speed of those transitions, the speed of those changes, what accelerates these changes, and how may that look different in a Swedish context or in another country context compared with a U.S. context or another country context. How does that compare? How does that compare across different national settings and different social structures and different national healthcare systems and national healthcare policies? I find that really, really fascinating to think about that rate of change, the rate of accumulation, and also the rate you mentioned that having a long enough follow-up to be able to observe substantive changes and underlying multimorbidity, but also what are those critical time periods? What are those critical age spans? And looking earlier in the age span so that we can capture those critical changes for folks who develop things earlier who may not survive until the older age groups.
Exactly. And I think if I can add one thing there, which I think is a limitation, a big limitation of our work, is that we have started very simple, and you can see all of our graphs are like straight lines. One would think, wow, so diseases accumulate in a very proportional, linear way, right? But this is artificial. This is because of the type of models that we are applying. These are linear mixed models. We are trying to start from the very basics to see if indeed there is an association that is significant both in statistical but also in clinical terms, But I think the way forward is in going into more sophisticated models that enable you to capture that change and dynamism in a bit of a better and more realistic way. So that's, I think, the way forward. Now we see that this speed of disease accumulation, or the rate, seems to be clinically plausible, and there is some reasoning to believe that it's a good proxy of this rate of aging, as we were saying before. Now we have to do a better job in capturing it and in measuring it. So that's definitely one way ahead, at least for us. Indeed, yeah.
Yep, absolutely agree. Emily, do you want to jump in?
Yeah, I would love to share a few thoughts. Thank you both for your very interesting discussion on these talks. I think you've already covered a few of the things I wanted to say, but I really appreciate that you've mentioned the importance of studying these processes over long periods of time, because I think we often see these linear lines and assume, oh yes, everyone's just very straightforwardly living their lives, but that's not how people's experiences really are in real life. And especially for my study, looking at these long-term recoveries after marital transitions, like, we can't assume that these are steady, but that these are happening they're fluctuating over long periods. And the importance of understanding what predicts those fluctuations is also very important. Looking at those social factors, looking at our social relationships, looking at cultural differences and how that interacts, and also the importance of intersectional perspectives, looking at how this interacts with race and ethnicity, with gender and sexuality, with class, and all these different things that are going to support some people more than others in their experiences.
Absolutely. That's great.
Completely.
Well, we have about a minute and a half left. Was there anything else that jumped out at you? I mean, I think this is actually quite a nice way of summarizing. And Emily, I think you really put a nice period at the end of the discussion for really summarizing across the three talks the importance of what we each presented, where the field is, and what we should be looking for in the future in terms of where can we advance and where can we progress and where can we learn more. So I've learned quite a bit. This is really wonderful. Very productive 15 minutes.
Thanks for inviting me and for this very nice talk. And I think we have a nice symposium. Hope that the audience enjoyed it also.
Yes, of course.